Hey, Ron.
Hey, how are you?
Good, good. Nice
Good.
to connect. And
Yes, yes,
how's,
yes.
yeah, I appreciate you taking the time. How's your
Oh,
day going?
my pleasure. It's going well.
Good.
Another Wednesday in this time.
Yeah.
How about yours?
Good. Yeah, we had a good day. We launched a new website and exciting stuff at work.
Nice.
So it looks like you're in scrubs. Did you operate today?
I'm in scrubs. This has become my attire of choice, actually.
Yeah.
Dermatology, we see acne patient one minute, next minute we're excising a big cyst. So the days of wearing ties and being spreading bacteria, I kind of gave those up and just went to the nice embroidered scrubs.
Okay. Very good. All right. So tell us a little bit about your practice. You started a couple of years ago in Frisco, and um,
Yep. We are so Prism Dermatology. We are a newer practice. We opened up last year at the beginning of 2019. So it feels like a long time ago, especially since the last 2 months have felt like 2 years.
wow.
But we are in the Dallas Fort Worth area. We're in a suburb called South Lake, Texas. And we are a full spectrum dermatology practice. So, I like to cast a wide umbrella where I'm seeing kids, adults, skin checks, acne, procedures, lasers, cosmetics. So I try to do a little bit of it all.
Right, right. So you grew up in Columbus, Ohio, home of Buster Douglas.
Yes, home
Yeah,
of Buster Douglas. They're good, good,
that's
good.
right. I spent a month there, and I saw him knock out Mike Tyson
Oh,
on
nice.
on TV. Yeah, it was in February of I think 1990. Yeah, yeah,
Yeah. So
yeah.
my father was a boxer and actually either trained with Buster's dad or Buster's dad, and he trained at the same gym. So it's kind
Yeah.
of like that name is like Columbus lore.
Oh yeah, yeah.
Yeah.
That's fun. So did you do some boxing growing up?
I was 0 for 1 for my lifetime. So my dad got me into boxing at around age 4 or 5.
Yeah.
And one fight, took a punch, and I just kind of laid down. I guess from watching TV, I thought when you got hit, you were supposed to lay there. And so, it wasn't a hard punch, but my dad was like, get up. And I was just kind of laying there watching him look at me. And he decided that was it. That was it for my boxing career.
Yeah. So how old are you?
I was about 5. I was,
Five. Okay. Yeah.
yeah. So we were just doing this, it kind of looked
Yeah.
like those toys back in the day. You just kind of punch
Right.
each other, but I didn't know what I was doing. So
Right. So Columbus, a big sports town. You big Ohio State fan? That's in your blood,
absolutely.
right? Got a
I,
tattoo and everything.
not that far. It's kind of tattooed in my heart. I'm
Right.
a Buckeye. My wife will probably um, tell you how much I love them. So the fact that I was watching old Ohio State games last week as if it was brand new.
Oh,
Um,
okay. And
so
she's in your wife. She's from where's she from?
she's from the state up north, and that's someone from Ohio. I can't really say that word,
Oh,
but
Michigan. Must
it's
be
a state right above, somewhere up north
up
from us.
north. Okay. Okay.
Yeah,
Wow, that's a fun household.
yeah.
Terrific. So, what are you doing during this time period with COVID? What happened? Tell us in the last couple of months. What you guys do in your practice?
Well, let's start with around mid March. We were all figuring out what was going to happen, and in the practice, no one knew what
Right.
to do. How to protect our patients. So one of the things that we decided to do was just try to be proactive in calling patients and saying, hey, I think things are shutting down. I believe at the time, the county next to us, which is Dallas County, started to slow things down before Tarrant County, where my practice actually sits in. We're right on the edge, so we get
Right.
patients from both counties. I kind of took the lead of Dallas County and what they were doing, taking some of the recommendations and precautions for our patients. And then once everything shut down, we as a practice shut down as well for our routine services.
Right.
We started to initiate the telemedicine services, and we still saw patients in the office until we were unable to, based on some of the shelter at home and the state regulations. But some of the emergent things, we were still bringing patients in with precautions, mask, gloves, hand washing, separating visits, and that's those are a lot of the measures that we're taking even now.
Right. And you're back. Are you back full bore or half?
Yeah, we've created a template to allow patients to come in, be seen, go to checkout even before the next patient was to come in. And so this allows patients to feel comfortable. So with that being said, the day is each visit's a little longer. We're seeing about half of the patients that we probably normally see at this time as a result, but at least patients are safe.
Right. And what is your feeling that how things are going in the state of Texas as far as opening up? At what point will you be 100%?
I was hoping you would tell me the answer to that. It's one of those things you really don't know, right? When is it safe? As we follow the phases that the governor has laid out for us, I'm trying to just get a temperature of what the patients are feeling. And I think it honestly will be a slow transition. I plan to personally keep the schedule lighter than I guess I normally would, as to make people feel comfortable, and also continue to offer telemedicine visits. I think those have been a really great bridge for the patients who can take advantage of those. But I'm looking for the next 4 to 6 weeks to really tell me what to do, especially as we hear the news of more cases in Texas, and the single highest jump in cases, and determining if that's from testing or if that's from true active cases. Once that gets clear, I will have a better idea of what we're going to do with our practice.
Right. Well, it looks like Texas is doing fairly well, except for a few towns like Amarillo. It's a hot day. El Paso as well. El Paso also had some, some hospital capacity concerns. So I think the state of Texas, by and large, done a pretty good job, especially with nursing home protection. So
I agree.
Good living here. Yeah, it's good. It's good. So tell me, in your own life, what are the top 2 or 3 things that you do that are just like that you feel that you need to do to protect yourself or your family? What are the top things?
Well, I would say prior to COVID, my wife and I like to get out, fly, go vacation or visit friends. And that has really taken a back seat at this point. I think that's in the best interest, not only for my family, but for my patients, making sure that we are, as much as possible, staying home, taking necessary precautions when we are going out. And that's probably the second thing that we've changed. We're not traveling as often, but we're also some of the normal day-to-day weekend activities, we've cut back on those significantly as a protection to ourselves, but also a protection for my patients, because I'm still going in every day and I don't want to put patients at any unnecessary risk.
Right. Yeah.
At this point.
Yes.
So that's been a tough personal sacrifice.
You're limiting your activity outside to help your patients. Yeah. Yeah.
And it's, and honestly, I think it's best. I think this past 4 to 6 weeks have taught us, what's really necessary, or what things can we streamline? How can we make life more efficient without putting ourselves at risk? But at the same time, I miss going to the movies. I miss going, at the end of I was supposed to go to a Mavs game, before they shut the NBA down. So little things like that, you miss those social activities. Right.
So let's talk about medicine. So what are you seeing more COVID related in your practice? The masks or the COVID toes? What are you seeing related to COVID in your practice?
So we've gotten some information in the dermatology community about, what are the COVID associated rashes. And I've seen a couple of potential cases of COVID toes. That finding is something that we see in other dermatologic conditions. And so one of our jobs is to tease out, is the patient antibody positive versus is this a finding that's associated with one of the more classic reasons for the changes that we see with the hands and the toes in patients with COVID. Another big distinguishing factor is looking at rashes. Rashes are one of the aspects that a lot of physicians in general are like, go see a dermatologist about. But now, as dermatologists are seeing rashes that we classically associate with other viruses that are more common, that we're starting to question, is this a rash from a virus that we see every day, or is this a COVID rash? And what do we do next? Those are some of the big challenges. However, other issues that I've come across are just contact dermatitis, mask, irritation. People are at home more than ever. So they're washing clothes more than ever. So they're now determining, well, I might be allergic to this soap that I may have used once or twice a month, maybe, depending on how often you wash, versus having to wash clothes more frequently and developing these types of rashes. So a lot of occupational and exposure dermatitis or dermatology issues I'm seeing in the office now.
So so the COVID toes, what other conditions do you see that type of presentation?
Well, when we start to see what we call vascular changes in the hands and feet, we think of a couple conditions. One being Raynaud's phenomenon. That's just basically changes in vascularity or blood flow to the hands and feet. And that's not quite what COVID toes looks like, kind of when you look at the classic pictures that we see now, but that's something that pops into the mind. Another issue is just perniosis, which is a condition.
What was that again? What was
pernio.
That? Okay.
Pernio, Pernio. And that's a condition where you can get these classic purple, red, deep red changes in the toes. And that can be something that's associated with other autoimmune conditions or something that can be idiopathic and just related to the individual patient or their environment, whether it be cold temperature or weather associated changes.
Yeah. Hey, you got a lot of fans. We're getting a lot of activity, high fives and clapping.
I see a couple of my Cincinnati Bearcat colleagues, friends from Cincinnati. They probably didn't like that Buckeye shout out I gave them, so I have to make sure I give a Bearcat shout out.
Yeah. Well, you got a big following here. Thanks everyone for following. I see Dr. C. Robinson, MD. So who is that? Do you know C. Robinson, MD?
Yes, Dr. Robinson. She's a fellow dermatologist in the Chicago area.
In Chicago area. Okay.
Yes.
Okay. Very good. Yeah, in cardiology, you would see those COVID toes and, in smokers, emboli. Mm-hmm. Usually when you have atheroemboli from the aorta, which just embolizes, post-procedure,
mm-hmm.
where you scrape a catheter down the aorta and there could be an aneurysm that's shedding that little clot. So, so it's very, very interesting, to see all those images. It looks like a cardiac patient who's had a complication post-catheterization.
Yeah, and these are young 30, 40-year-old patients with these findings.
Right.
And so, what do you do? It's outside of your typical case of a post-cardiac issue. Right. So, for example, a patient that comes to mind that had similar findings, my main concern was, do I do an autoimmune workup or am I doing a hypercoagulable workup?
Right.
Or both. You kind of shotgun approach versus, being specific. Yeah. It's hard to say at this time.
Yeah. I have a lot of respect for dermatologists. They have over 3,000 diagnoses that you guys have to deal with. And the diagnosis books are quite large. You're great with differential diagnosis. So I always want to have a dermatologist or a dermatopathologist on my team for Quizbo, in medicine.
Yeah.
You guys see a lot of different things. That's very good. So
it's a lot.
What's that?
I said it's a lot. There's a lot of minutia, but it's fun. It's fun.
Yeah. And there's somebody who wants to be a dermatologist. So tell me, how did you go into dermatologist? How did you get into dermatology? What was the road? We know that's the hardest residency to get into now.
It
So
is very challenging. A lot of competition just from the pure nature. It's a small field. My personal story in dermatology, I actually went into med school. Dermatology wasn't on the radar for me. It wasn't something that I went into school wanting to do. It was actually a friend of mine who was like, you should think about dermatology. So luckily, the beginning of my third year of medical school, I was able to do a 2-week rotation in dermatology. In that 2 weeks, I met my mentor, Dr. Hugh Gloucester, who gave me great surgical exposure in dermatology. I rotated in the pediatric hospital and saw these bullous conditions that are like 5 out of 1 million cases. And every day was new. Every day was different. The next day we were in general clinic, and the next day we were in a rare disease clinic. And in 2 weeks, I was like, man, this is the most amazing thing I've ever seen in medicine. You know, it was different than the exposure I had previously, where maybe in internal medicine, where you may be in an outpatient setting, you're seeing a lot of the same things. In 2 weeks, I saw diagnoses I'd never heard of. And I said, this is it. I want to be a dermatologist. I can do surgery on Monday and see acne on Tuesday and do other procedures throughout the week. This is amazing. So from that point, kind of focused in on becoming a dermatologist.
and you had to have good grades too. You did well in college, and
Yes.
yeah.
One of the barriers, I guess, that we have to overcome for all medical students is just those step scores. So step 1, step 2, those are the standardized tests that physicians take or medical students take on their road to being a physician. And you have to do well. I know there's some changes now with the step scores and the new medical and the new scoring. So I'm interested to see how that translates to how the demographics of different specialties shake out with the changes with the USMLE scores.
Right. So what challenges did you have in your training and going into practice? What were some of the highlights that you thought were, wow, somebody else could learn from this?
Well, one of the things, I guess, early on, kind of going back to that time in medical school, was I was fortunate enough to have a mentor who looked like me. And that is something that was few and far between. And so being able to have African-American dermatologists in my presence to kind of show me the way was really important. I say one of the barriers was just, knowing about dermatology in the first place. It's not something that when you're in medical school that's kind of in the forefront of one of the specialties. It's something that I stumbled upon, and many of colleagues have also just kind of found their way into the field rather than it being something that was shown to them. And then just getting into the field in itself was a challenge, but I'm glad we made it. I had a really good support system at my training program at Wayne State in Detroit, Michigan. My co-residents, we were named by our chief resident, Team Awesome. They were an awesome team of just supportive co-residents who just helped me along the way. Dermatology, as you mentioned, is such a vast field with 2,500, 3,000 diagnoses. It really takes a lot. It's a lot of reading, a lot of learning. And the first year is tough. I mean, you're thrown at a lot of diseases that you've never seen. And many pictures of conditions that you probably will never see, and you're forced to remember these things. And so another challenge was just, taking that next step in my education and kind of deep dive into dermatology as a field.
Yeah, we had Dr. Wendy Roberts on last week, a good friend of mine, and I've been to some of the skin of color meetings.
Mm-hmm.
It's a very significantly different pathophysiology that you see in skin of color, and there's a huge need for people of your background going into the field, as it is in really any field, cardiology, et cetera.
Yeah.
Dermatology, there are only 12,000 dermatologists, I think, in the U.S., and internal medicine and family practice and combination, it's about 300,000. So it's terms are really, really small field, and everybody knows each other. So you got to be in good behavior. Don't burn any bridges.
That's true.
Because they're gonna find you or talk to somebody that you've met and so on and so forth. That's great. So let's talk about some of the folliculitis and hair conditions that you see that need special attention in the African American population. So talk a little bit about that and maybe how our product maybe helps in that area for your practice.
Sure. So I'm glad you brought that up, because one of the biggest lessons that I learned in training was you can be book smart, you can have all the knowledge, but having perspective about your patients is invaluable. And so understanding some of the cultural aspects of skin, of health, some that we see as dermatologists will help you in aiding your diagnosis. Let me switch this here.
You got a lot of people liking you.
Yeah, I'm sorry. Can you see me okay?
Yeah, I can see you fine.
Okay, cool. I was making sure it didn't blur. So back to your question. One of the issues in the African American community, but also in skin and color in general, is hair loss. Hair loss is often thought to be solely genetic, but there are a lot of inflammatory hair loss conditions. And those are conditions characterized by some type of swelling, inflammation in the scalp, whether it be folliculitis, which is inflammation around the hair follicle causing hair loss, or scarring hair loss, which can cause more of a long-term permanent hair loss in the scalp. That kind of spectrum of condition is very common in my practice, as I see a lot of people skin of color, and I tend to see a higher percentage of those scarring or inflammatory hair loss patients being patients of skin of color. And being able to address them culturally, making sure you give appropriate recommendations based on their hair type, how they may groom themselves, is important, because the last thing a patient wants to do is come to a doctor who gives them recommendations they can't use. And so having that extra education about culture is really helpful in that.
So what is the scarring you're talking about? Is that from the weave or
yeah, so
braiding?
there are conditions, one of which is very common, called centrifugal cicatricial alopecia. So very long words, but we say CCCA for short. And that is a condition historically that we thought was related to hair care practices. So as you mentioned, weave, extension, chemical relaxers, thermal heat to the scalp. But we're finding now that there's more to it. There's a huge genetic component. And some of those factors may be the second hit, or, to the two hit hypothesis. You're predisposed to having it, and now you have some of these factors that may contribute to the onset of the disease, and voila, you have this scarring hair loss, generally on the top part of your scalp here, that causes permanent hair loss. And as you can imagine, especially in our female population, this can be not only disfiguring, but psychosocially, it can be damaging to our patients.
So what percentage of the effect is genetic?
That's a very good question. We actually have some great new research coming out about a certain gene that is isolated that may put you at risk for this condition, and also other conditions that may be related to it. So we're finding that this condition may be related to women who suffer with fibroids. So we know from our GYN colleagues that fibroids in women of skin of color is a big growing issue. And as dermatologists are finding that there may be a correlation between the two.
Oh, I didn't know.
Yeah, it's not quite hot off the presses, but it's kind of a new thing in the last few years that we're determining. We're moving away from blaming everything on hairstyling or cultural, and realizing that there are some genetic components to some of these conditions, and these are things we can address before we get to having these long-term scarring issues.
Okay, so when you see a patient like that, you go over the family history? Is it the mom or dad that they inherited from? Does it have any sex preference, or?
Honestly, it's something we see most commonly in females. And it's hard to say if that's solely because of how the genes work or if it's a matter of care. A lot of men suffer from scarring hair loss, but may have aunts, or I'm sorry, may have uncles and dads who have hair loss, and they think, well, this is just normal. This
Right.
is how, you know, how it's supposed to be, and
Right.
they oftentimes don't seek medical care for it. And so,
Right.
I'm interested to see as we get more education about what kind of hair loss diseases there are,
Yeah.
if we start to see more men present with symptoms that we can treat.
Okay. All right. So let's move to the beard. What do you do for the PFB and folliculitis there? What are your tricks of the trade there?
So pseudofolliculitis Barbae, or PFB, it actually used to be one of my favorite things to treat because that's actually something that I suffer with. Hence the beard. This is more of a COVID related beard. I'm usually not this full of a beard, but one of the things that I've fallen in love with lately, honestly, is the CLN facial cleanser as a maintenance. A lot of the issue that we see with the inflammatory PFB, so those are the pimples or the red bumps along the hair, is secondarily due to the inflammation and bacteria in the hair follicle. So if we can reduce that, that does go a long way as we're starting to treat with retinoid products, other exfoliating products, topical antibiotics that we apply to the skin to just reduce the redness and the propensity for the ingrowing hair. So for those who aren't aware, pseudofolliculitis Barbae is razor bumps or hair bumps along the beard line, often due to the ingrowing of hair or the growth of hair through the skin.
So you use the facial cleanser with the glycerin and sodium hypochlorite, that one,
Yeah,
or the one
yes.
without? Okay. Yeah.
I use the facial cleanser. I actually use both the facial cleanser and also the acne cleanser,
Okay.
depending on the patient. So I do appreciate the salicylic acid. I think that does have an effect for patients where I need to get a little bit more penetration into the hair follicle. Salicylic acid is helpful in that sense.
Yeah, so the acne cleanser has a sal acid and sodium hypochlorite, whereas
Yes.
the facial cleanser has sodium hypochlorite and glycerin.
Yeah.
Um, so you can mix and match. Use it as a pre-shave. Some of my friends use the facial cleanser to actually shave with as well.
Yeah, I have a few patients who do that as well.
Yeah.
Mostly for men, right? So another cultural phenomenon that I guess dawned on me is that men are pretty lazy when it comes to skincare. And so the easier you can make it for us, the better outcome. So
Sure.
if you could skip a step and just use your cleanser, which is also therapeutic to help with shaving, I mean, that's kind of a 3-in-1 benefit right there.
Right. What about other, you said the retinoids, how to use that in PFB?
Retinoids are generally applied 2 to 3 times a week to start, up to nightly. So I find that retinoic acid can help reduce the inflammation that's associated with the PFB, so the redness. It also helps with keratinization, so how our skin matures over time. And although the pathophysiology or the cause of PFB is not always from clogged pores, if we can help with skin resiliency by improving the way it matures week to week, that can reduce your risk of ingrowing hair, but it also can help improve the appearance. So a lot of the issues that we have is just darkness in this area from shaving, from irritation, and retinoids can help reduce that dark appearance there, in addition to other exfoliating acids like the salicylic acid.
Prescription or over the counter?
I generally do prescription. If they're coming to see me, a lot of men are savvy. There's a lot of great information out there on blogs and such. So people have tried retinoids, but I usually do a prescription in addition to a medical grade cleanser or exfoliating product.
Okay. Okay. We have a question
Sure.
from someone. You know, what do you think of Theradome and laser cap for hair restoration?
So Theradome, laser caps, those are examples of low-level light therapy. So it's a low-level red light, a visible light that is, there's evidence that red light can help stimulate hair follicles and hair growth. It's one of those products that I say there is evidence for it. However, will it work for you versus the next person versus the next person? It's really hard to determine that case by case, but I generally use it as an additive to my treatment. So whether we're on other therapies for your hair loss, we may add that to your routine because low-level light therapy is a efficacious treatment for mostly androgenic or male or female pattern hair loss.
So those lights are for androgenic?
Yes.
Yeah.
So the back up, those devices have good evidence for androgenic or pattern hair loss.
Okay. Okay. Very good. And use Propecia and
Yeah.
minoxidil as well.
Yeah, I use the standard therapies for, especially for men, Propecia or finasteride at the 1 milligram dose. It works really well. We also have some other tricks up our sleeve for those who are a little weary of finasteride. Other medications orally, such as minoxidil, sometimes we'll use with our cardiologist.
Orally?
With our cardiologist blessing.
Yeah. Well, as long as they've got good blood pressure, yeah.
Bingo.
Sure.
And so this is something that in Europe and Canada that a lot of dermatologists have used for years. It is not, oral minoxidil is not FDA approved for the treatment of male pattern or female pattern hair loss, but there is strong evidence that is efficacious in the right patient.
Right.
So making sure we do, dermatologists are first doctors, internists even. So we got to make sure that we're making sure the patient has adequate blood pressure, making sure they're not on other medications that may cause issues. But yes, it is helpful in the right case.
Right. Good. We have a question about curly hair product being comedogenic. Can you comment on that? The oils and so on are comedogenic.
Yes. Yes, and that is a very common issue that I see, especially in younger females generally, especially skin of color, where we're using heavier oils to maintain the hair, especially along the edges of the hair. And so what that question is describing is when the oils that are for your hair tend to drip or fall down onto the forehead, you can develop acne, closed and open comedones or blackheads. And so one of the things that I counsel when I'm treating those patients is how to prevent that, whether you're applying something along the hairline prior to applying oil so that the oils don't get into the skin, into the pores of the forehead skin, or if you're focusing on using washout products or lighter leave-in products in the actual scalp rather into the hair.
Very good. So let's talk about aesthetics in men. So what are you doing in the office? What are you offering? I need a little Kybella myself.
Yeah, the great thing about men in this 2020 day is men are aware, right? Whether it's Instagram or Facebook or their wives or even their friends, we're now talking about these things. I mean, for generations past, men didn't talk about skin. They didn't talk about what they did, and if they did something, they kind of kept it to themselves. So one of the big procedures that we do in our office for men are lasers, actually, whether it be radio frequency microneedling lasers, which are designed to help with tightening the skin, reducing pore sizes, mechanical microneedling. So that's using a device called a skin pen to stimulate collagen to reduce fine lines and wrinkles, but also reduce the appearance of pores. Those are big sellers for men, but also Botox. I think Botox has become, I've treated more men with Botox probably in the last year than I had in the previous 2 or 3 years. I mean, I just think men are becoming more aware. The stigma around it is becoming less, and they realize that, a couple lines show some maturity, but you don't need to have the deep ones. You can have a little light line. I mean, that's where the goal is. And I think, being able to see someone who is trained, who knows how to dose you appropriately, can give that natural look for men.
Yeah.
Where we're not feminizing the areas around the eyes or the brow shape. Those are things that it takes the right hands to do.
Right. And we see a lot of young kids getting toxins too. college age and companies are marketing to them? What do you think of?
Yeah. Prevention,
Yeah.
the ounce of prevention versus a pound of cure, that's kind of translating into aesthetics at this point, whether it be with Botox or hyaluronic acid fillers or even products, making sure you're using the right products. People are realizing that, uh, a small investment year to year can maybe save you from going under the knife 20, 30 years from now.
Right.
I think that's as we become minimally invasive as a medical society, people are looking towards prevention before they have to go into the big surgeries.
How about fillers, and are there any special precautions with skin of color and fillers?
Yes, that's a very great question. I'm glad you asked that. One of the big issues that we try to mitigate with our skin of color patients is hyperpigmentation. So hyperpigmentation is blemishes, what people think of as acne blemishes or dark spots. And that's as a side effect of inflammation. Using fillers, although we generally have great technique, the more needle punctures, the more trauma you do to a person of skin of color, the more risk or increased risk you can have of issues like hyperpigmentation or dark spots. So taking necessary precautions, using blunt tip cannulas instead of needles in skin of color can help reduce your overall need for or amount of injections and therefore reduce your risk of blemishes in skin of color.
Let me clarify that.
Mm-hmm.
You for delivering of fillers, you're using more blunt tip.
Yeah. So traditionally, for the last few decades, fillers have been introduced into the skin using needles, usually small gauge, 27, 30 gauge needles. However, that does require multiple punctures. If you're treating here and here and here, you have to stick in all those areas. Over the last few years, we've developed techniques as dermatologists where we can use cannula. So instead of doing multiple punctures throughout the skin, we can enter in one or two areas using 1 inch up to 2 or even longer inch cannulas and place the filler where we need to place it. It's also safer. Those blunt tip cannulas, although um, they can cause issues with the underlying vascularity, they're less likely to cause bleeding and bruising than the sharper needles that we've used for decades.
So you better know what you're doing with that, with knowing the anatomy. I mean, to me, it seems like a bigger instrument, but you're re-entering less often.
Yes, and that's a
That's
great
the,
point. Know your anatomy. So
yeah,
when I teach residents, when I talk to med students who are interested in dermatology, I say, you know, dermatology, as you alluded to earlier, it's not just skin deep. That sounds so cliche, but you have to know what's underneath. You have to know your anatomy, whether it's skin anatomy, facial anatomy, head and neck anatomy. You have to know your histology, your what's going on in the skin. I mean, we go through all this training for a reason, and so I really appreciate when my patients have an appreciation for what we learn and what we know.
right, right. And being, board certified, having gone
Right.
through the curriculum is really critical because, some of these fillers can end up in small vessels, especially if you're around the eye and
Absolutely.
embolization. So tell us about some of the paralysis or embolization that these fillers can be associated with placed in the wrong place.
Yeah. So around the eyes, around the mid face, the nose, and the lips, there are several large vessels that all interconnect. So the heart, which I know is near and dear to you, has several blood vessels that kind of travel north. And as you travel north, these blood vessels supply blood literally to your entire face and scalp. And so by putting a thick filler into a vessel that may be supplying blood flow to your face, you can actually disrupt that blood flow and cause really severe issues to the skin. Not only that, if you're going towards a vessel that's closer to the eye, those vessels connect to the blood vessels that connect into the brain, into the inner eye area, and so you can cause blindness by injecting into a blood vessel that communicates with the internal carotid system, as you're well aware with.
Right, right. Well, so So when you're doing the fillers, I imagine you have to be ready to undo them as well, right? Or
Yeah,
to be able to reverse it or remove. Do you reverse or remove? What are you ready for?
we have to be ready for it all. So the most fillers are hyaluronic acid based. So hyaluronic acid is a sugar that absorbs water in a sense. And there are products that we can inject in the areas where there's concern for vessel occlusion or closing off of a vessel, where we can melt that hyaluronic acid filler before you have some serious complications. Now, there are some fillers that are irreversible, whether it be collagen based fillers or calcium hydroxyapatite based fillers. These we don't really have great reversible products to inject. So your first step is prevention, making sure you don't get into a vessel, followed by knowing what to do if you do have concerns for some vascular occlusion.
Right, right. Well, yeah. I would tell my patients who would come and see me in second or third opinion, like, hey, well, why should I have you do the procedure? I go, well, 95% of the time, anyone can do it. It's about 5% of the time that if there's a complication, I can bail you out, or maybe somebody else may not.
Right.
And, most of the time people can go get these procedures in a lot of places, but you've got to go to a place where they do a lot of them and can bail you out or avoid the problems and the pitfalls where many without the training are not going to have that.
Yeah, absolutely. You can't put a price on safety. So that's my
Yeah.
tagline. Like, you know, is your safety worth the extra, your safety and your assurance worth the extra, whatever it may be, to make sure you're in good hands? I mean, that's right on line.
Right, right. So do you do, what do you do outside of the face? What other procedures? Do you have any aesthetic procedures outside of the face? Or you?
Yes. So lasers. Lasers is probably the biggest thing we do outside of face. And backing up a little bit, we also do fillers off the face. A lot of people aren't aware that fillers can be used off the face to help with skin laxity, skin tightening. So whether it be into the neck and décolleté, and female patients who are looking for some rejuvenation in the chest or even around the
Okay.
elbows or the knees, fillers can be done there as well, but also lasers. So we do have laser procedures that can help with skin tightening. We also do at my practice a procedure called profound radiofrequency, which is a device that can help treat cellulite on the legs or localized areas of fat, whether it be the lower abdomen or the flanks. This is a procedure that can kind of help melt that fat, but also provide a little bit of skin tightening, and is really good for people who either have cellulite or localized fat, or people who have done procedures like liposuction who may have a little bit of skin laxity. We can actually tighten the skin using that profound radiofrequency device. So that's fun.
What causes cellulite? What's the pathophysiology of cellulite?
Genetics is probably one of those things again, but I like to describe it to my patients as, when we have our skin is supported by a level of fat. And between the fat and the skin, there are these attachments. And over time, things happen. The skin becomes thinner, those attachments become looser. So now you have in between those attachments, the fat underneath kind of protruding up. And so it looks like dimples. Imagine the outside of the dimples being those attachments, and then the inside of the dimple being the fat pushing up on the thinning skin. And that can be related, as I mentioned, to genetics, but also lifestyle, activity level, body habitus. All those things can, again, be that second hit to the predisposition for cellulite.
So what lifestyle would lead to cellulite?
Well, it's not one of those things that are, if you do this, you'll get it. But people who are standing a lot, people, honestly, I've seen it both ways. People who are sedentary and people who are on their feet a lot. Kind of those two extremes may see some changes in the posterior thigh, lateral thigh area, which appear as the dimpling of the cellulite. And I counsel my patients, you're not doing anything that 1,000 other people aren't, but you may just be predisposed to
Right.
developing these cellulite.
Right. How about smoking?
Smoking, that's the catch-all, right? Smoking, from a physiologic standpoint, it's giving yourself a lot of these bad free radicals, which can cause early skin aging. And so one of the issues in cellulite is just the thinning of the overlying skin, which could be from degradation of collagen. So that's our support in our skin. And those free radicals from smoking can definitely reduce the collagen production, but also the collagen you have. So absolutely.
So can you supplement collagen orally? I see all this collagen drinks and all that. Is that hocus pocus or is that real? How does it get through all the GI system and get absorbed?
Yeah, the jury's still out. I think that oral supplementation of collagen is useful. I don't know how useful it is. I know it doesn't hurt, but to your point, ingesting collagen orally, it has to go a long way before it gets back to your skin. And so I can't guarantee that you're going to have miraculous collagen production from taking oral collagen. However, that's where we supplement with topical products such as peptides and oxidants that we apply to the skin to just stimulate the skin directly to produce more collagen.
Right.
I'm more of a fan of the topical application, honestly, just because those things have been tried and true and studied over the years.
Yeah, the skin doc just joined. Hello, skin doc. I'm late, sorry.
Hey, skin doc.
Hello,
That's
skin
another
doc.
colleague in the Washington, D.C. area.
Yeah.
She's an excellent dermatologist.
Let you get away because you trained in, did you train in Detroit? Right?
Yep, I did. I did.
So you probably saw a lot of HS there. I mean,
I did.
And so what do you do? And it's such a tough disease, and it spills over to cardiology and
yes,
fatty liver and metabolic syndrome.
Absolutely. So hidradenitis suppurativa is HS, and I did see a lot of it in Detroit. Hidradenitis is a condition that affects the axilla under the breast, the growing area where we get these boils or cysts in the areas. I still try some of the tried and true therapies, which are combination antibiotic therapies, whether it's tetracycline class, clindamycin, rifampin, are kind of my early treatments. But the biggest benefit in the last few years is Humira in the treatment of hidradenitis suppurativa. So that's a biologic medication that we use. I tend to do combination treatments. So topically, I'm going to prescribe clindamycin topical. I'm also going to recommend a cleanser such as the CLN body wash to help reduce bacteria on the skin and also reduce some inflammation and maybe some itching that patients may have. I'm also going to prescribe oral medications used in combination, generally 2 antibiotics at once to control bacteria inflammation. And if all that fails, we go to our bigger treatments such as the Humira injections.
Right. And are there any procedures that can lead to HS? Are there complications of any of the procedures for sweat glands and so on that as a complication people get HS?
I haven't seen it much as a complication. Now, anything that can cause severe inflammation or scarring formation in the areas of those apocrine or sweat glands can cause HS-like changes. But there is, again, we're on a strong genetic kick today, but there's a genetic component or predisposition to it. But also body habitus. So another thing that I like to do is counsel on 2 things that we know affect HS, and that's tobacco use and obesity. So if you're overweight, you're more likely to have HS, but also progression of your HS through the stages, where it's getting from mild to more severe.
Right. And is it just my perception that the incidence is increasing, or is it there's just more awareness because Humira is advertising? And
I think it's a little bit of both, to be honest with you. I think I oftentimes have patients who say, my mom had this and she just dealt with it. Yeah. And so I think there's more awareness. Again, we're the social media era, we're more open with each other. But I also think the incidence of obesity is up. And so is there a correlation there? We have, I'm interested to see how younger generations, not to date myself, but Generation Z and younger generations with the increase of vape pens or nicotine use or other tobacco use, if that has an issue that will increase the incidence of HS. It's interesting to be seen.
Right. So what generation are you?
I'm what they call millennial, so
Okay.
we're technically Generation Y.
Okay.
My mother calls everybody under the age of 40 a millennial, whether you're 13 or 40.
Yeah.
But I am a true millennial, 85.
You're
Born.
outside the norm. I just don't, you're a hardworking person who produced,
I saw, social media. I have more time on that now, but someone posted a picture. It's like, hey, baby boomers and Generation X.
Yeah.
I am a millennial. I am 38 years old. I have 3 kids and a job, but I'm a millennial.
Yeah.
The people you're talking about are Generation Z. That's the 22-year-olds. It was interesting because, again, anybody under 40 is a millennial, according to my mom, who's a boomer. So.
Okay. All right. Fantastic. Back to HS, I think the psychological impact of the disease is just enormous. I mean, I've learned so much dermatology over the years being now in this space.
Uh-huh.
But what they go through, I mean, could you imagine walking, you're going to work, you show up at the office, and all of a sudden one of the cysts breaks and they start leaking, It's like...
it's tough.
It's tough, it doesn't smell good. They lose their relationships.
Yeah.
It's a very, very difficult disease, and there are a lot of thin people who have it as well.
Mm-hmm. Yeah.
We don't really understand it. And then the surgery is really complicated. Do you do any HS surgery?
No, actually, in training, we did some minor procedures or excisions or also cryoinsufflation. So that's where you can go. So for people unfamiliar with HS, once these cysts become very severe, they can develop what they call these sinus tracts. So these are interconnections of these cystic lesions. And we used to do a procedure where we would either de-roof or remove the skin, allowing the skin to scar over, heal over, which will create less issues with those cysts. But honestly, since Humira and some other therapies that we've used for HS have come out, done far less surgery because surgery is permanent. Those are permanent scars. And if we can treat you medically first, and I've had some great success with the regimen that I've used as of late. But to your point, it's a tough condition. It's one of the 2 main conditions in dermatology that we study the psychological effects of. Psoriasis has a lot of literature about that, but also hidradenitis suppurativa, which I think those are both really systemic conditions that have cardiovascular effects. I mean, we're making sure that these patients aren't having metabolic syndrome, diabetes, cardiovascular events. I mean, it's a tough condition.
Yeah. Well, psoriasis, 30% higher incidence of heart disease than population, high, increased body surface area, abdominal girth, same with probably HS. I don't know the percentages, but it's higher as well. The other group that really suffers, I think all skin conditions, chronic skin conditions really impact, eczema in kids. It's huge, has a huge impact, learning, lack of sleep, et cetera. Yeah. Wow, we've covered a lot. What about what is that procedure that you inject a submental fat?
Kybella,
Kybella, yeah. Do you do any of that? I mean,
yes. So Kybella is an acid. Scary word, but it's a product that we use to melt fat. And this is the FDA approved area, the double chin. Even you can be the most fit person in the world, but if your genes tell you have a double chin, you're going to have a double chin. And Kybella is really excellent for that. We also use Kybella in other localized areas of fat. This is not something that is FDA approved, but in the right hands, we can melt fat in other areas of the body, including around the arms for, call it broad back fat or bra fat, jowling fat, submental fat. Those are fat around the knees, fat on the lower abdomen. Kybella is a nice fat melter in the right hands.
Right. And what kind of complications are associated with that?
Kybella, as I mentioned, is an acid. So you have to make sure that whoever's doing your treatment is aware of the anatomy. And so if you place that Kybella in the wrong place or in the wrong layer, you can cause some severe issues, not only to the skin overlying the fat, but also the muscles and, more importantly, the nerves underlying the fat.
Right.
And so nerve paralysis, nerve damage is a big issue with poor injection technique
Right.
or poor technique in general.
Right. 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 I imagine the injection around the breast is also going to be quite painful.
Yeah. So Kybella is and there are some techniques that we use. There are some techniques that we use to reduce discomfort. But it's actually a small volume. In the submental fat, we tend to do a lot more of the product than in some of the other localized
Oh,
areas of
okay.
fat. So I think the speed of the procedure is also a factor. I remember the first time I did Kybella, actually it was a year after training. We had someone come in to help us train, and I was so slow. And it took me so much, and so that pain, it just slowly builds up. It's kind of like putting your hand in the oven at the beginning when you turn it on, and by the time it gets to 400, it took me 5-10 minutes to get through the procedure. And by the time I was halfway, the patient was already on fire because it was hot.
Yeah.
I'm much quicker now with it because I've learned my lesson.
Good. Good. So move fast. Move fast.
Move
Yeah.
fast
Yeah.
and know your anatomy. That's the
Right.
trick to Kybella.
Right. Right. We're having tons of people join in. And so, what do you see? What are the next big things in your field? What are the top 2 or 3 things that you see that are coming around the corner that you're excited about?
Dermatology is such an innovative field. I think the device sector of dermatology, the things that we can do with lasers and laser medicine, laser surgery is excellent. Um, there are a lot of devices that are coming out to aid in some of the more traditional medical conditions, whether it be acne, rosacea, psoriasis. There are devices that are coming out to help aid in the treatment of those conditions. I think that's next. Um, Minimally invasive surgery, whether it be laser surgery or traditional surgery, the field of dermatology is taking a big leap in that. Whether it be skin tightening procedures, minor lifts, those are things that dermatologists are well trained and are able to do and will continue to lead the field in addition to some of the laser treatments. Those are the 2 things I'm most excited about.
So it's mainly laser based then.
A lot of it is laser based.
Okay.
A lot of the momentum in medical therapies are just in treatment. So we're looking to get more focused treatments for conditions.
Right.
As you alluded to, there are thousands of diagnoses in dermatology, and a lot of those diagnoses aren't well studied because they're so rare.
Yeah.
And so it wasn't until years ago, and actually it wasn't until recently, that there was an FDA approved biologic for eczema, atopic dermatitis. That's a condition that's been around forever. We know about it, but we've been using therapies in general that are not specifically for eczema. Now there are these therapies that are specifically for dermatologic diseases. Psoriasis being probably the lead, with there being the many biologics out there for treat psoriasis. But those same treatments, specific treatments to get specific results, that's becoming a commonplace now. Alopecia areata, so that's an autoimmune condition for hair loss. There are some medications that are being tested that are hopefully going to be available in the market to specifically treat those conditions. That's the exciting part of medical dermatology, just specific disease-specific treatments.
Right. And you see the results right away.
Much more
So,
quickly, yes,
yeah.
which is great for me
Yeah.
because,
Yeah. Yeah.
and my patients,
Yeah.
it takes a while. I wish I could do, the beauty about procedures, you do a cath, you do something, you fix the problem. One of
Yeah.
the things about dermatology, sometimes we have to give you a cream and send you home and hope that you use it. And then 4 weeks later, we get a result.
Right. Right. Well, listen, Dr. Bosley, Ron, thank